Good evening, everyone. Welcome to this INICET PYQ series. I'm Dr. Jazeer, your dermatology faculty. Could anyone confirm if I'm audible and visible? So, Shweta, thank you for confirming. So, I hope everything is fine. So, with INICET in the corner, I hope all of your preparations are going fine. And today we will be discussing quite a few MCQs from dermatology. Let's see how you are able to answer. I hope that you must have gone through these questions in the app. Thank you for confirming. So what we will do right now is we have several MCQs that we'll discuss today. So some of them in the INICET level, and let's see how far you're able to answer all of them. Clear? Without wasting any more time, let's begin with the first question. So here, a 6-year-old child presents with multiple superficial erosions covered with thick crust around the nose and the mouth. What is the most likely diagnosis? The question itself says that the patient is a child and this child is having some erosions and crusting. Okay, erosions and crust. So what you have to do is whenever you're going to deal any MCQ in dermatology, and if it is an image based question, always go to the image first, just try to describe the image and see if any differential diagnosis comes to your mind. Okay, so here I'll just zoom this image for you. So this is how the child has presented to you. So you can see that there are multiple lesions on the skin, especially over the face, around the lips, isn't it? Over the nose and all. And you can see that there is some crusting as well. So it may look like a pustule or it looks like a yellowish colored crust. Now come back to the options. So in the options, you can see that ecthyma is the first one, bullous impetigo is the second one, non-bullous impetigo, and the last one is cellulitis. So what do you think is the right answer here? Child, face, erosion, crusting. And I gave you another hint. It looks like yellow in color. So here, what would be the right answer? Yeah, because what happens is if it was an ecthyma, then the crusting would have been black in color, which we usually call it as a chocolate crust or a eschar. So we don't see any black colored crust. So let us easily rule it out. The second one is a bullous impetigo. So in this image, when you closely see this image, you can't find any bullous lesions. So this is also ruled out. Next one is a non-bullous impetigo. Non-bullous impetigo is a condition where a child may present to you with yellow colored crust, especially over the face, which is the most common site. So here, you know what is the right answer now? It should be a non-bullous impetigo. And the last option which was given is cellulitis. Now, in the cases of cellulitis, where exactly do you expect to see a cellulitis? Cellulitis, one of the most common site is going to be the lower limb, especially the foot region, isn't it? And this is more commonly seen in adults. And these adults may come to you with a complaint of fever because that is again a bacterial infection. Along with fever, the patient would also have a shiny skin as well. Isn't it? Red, shiny, smooth skin. So that is how a patient can present to you with cellulitis. So definitely here the most appropriate answer should be a non-bullous impetigo. So yes, so treatment, see in all these cases, all the four options that is given here, all of them are bacterial infections because ecthyma is caused by a bacteria. Bullous impetigo, non-bullous impetigo, even cellulitis is caused by a bacteria. So the treatment is essentially with antibiotics. So if you want more specific treatment, since impetigo is going to be a superficial infection, then there are multiple options that you can do. Either you can go for a superficial, topical antibiotics. It can be something like mupirocin, or it can be fusidin, or any cephalosporins. Okay, any cephalosporins will also respond very well for impetigo. So that is all about the first question. So always remember, apply the same basic idea. You have to describe the lesion and then try to correlate with the differential diagnosis. That would be the easiest method how you can solve these kind of MCQs. So with your permission, I'm just going to the next question now. Now see this question. A 7-year-old child has a painful bogey swelling in the scalp with pustules and crusting. 𝐂𝐻 mount shows fungal hyphae. What is the most probable diagnosis? I want all of you to give it a try. So in the chat box or in the comment box, can you please let me know what should be the most appropriate answer? Options are favors, chirion, alopecia areata, and dissecting cellulitis. I can see Synergetic, Tony Food, Dr. Ghazali, all of you are answering it as B. And I would also agree with you. This is going to be a chirion, which is a type of tinea capitis. It's considered to be an inflammatory type. Okay, so now let's see what happens in all these cases. Now here, this MCQ says a child, once again it's a child, presents with a painful swelling in the scalp. Okay, and since 𝐂𝐻 mount is positive, 𝐂𝐻 positive मतलब it is going to be a fungal infection. तो इतना तो पता है कि 𝐂𝐻 अगर positive है, it's going to be a fungal infection. So if it is a fungal infection, which are the two options which you can rule out? Let's go logically. So which are the two options that you can rule out if the MCQ says that it is a 𝐂𝐻 is positive for a fungal hyphae? Yes. So we can rule out. Which are the options you will rule out? Yeah. क्योंकि alopecia areata we can easily rule out because alopecia areata is not a fungal infection. It is a autoimmune disease. It's an autoimmune disease, isn't it? And you're very good, Synergetic. We can also rule out dissecting cellulitis because dissecting cellulitis is going to be a chronic inflammatory condition. It's not a fungal infection where the patient can end up in a scarring alopecia. The patient can end up in a scarring alopecia. Now we are only left with two, that is favors and chirion. But the typical presentation, a child is coming to you with a painful swelling in the scalp, easily pluckable hair, or some lymphadenopathy. All those things is going to be much in favor of the answer, that is chirion. And मुझे ये भी बताओ कि in the cases of chirion, okay, in the cases of chirion or any cases of tinea capitis, what is your drug of choice? What is your drug of choice? I can give you multiple options now for drug of choice. Is it terbinafine? Is it amphotericin? If is it clotrimazole, clotrimazole, or let's say ketoconazole? Yes, very good, Synergetic. क्योंकि favors is very common in Kashmir. I completely agree. क्योंकि favors है ना, it is going to be endemic in Kashmir, right? It is going to be endemic in Kashmir. So here the drug of choice is going to be griseofulvin. Okay, please remember that the drug of choice of all the cases of tinea capitis is going to be griseofulvin, because even if you get this kind of a question, remember in all tinea we go for terbinafine, isn't it? Terbinafine is the overall drug of choice in all types of tinea, but in the cases of tinea capitis, the most appropriate answer should be griseofulvin. Excellent. So now let's go to the next question. So moving to the next question. So what does the question say? A man with uncontrolled diabetes presents with fever and black necrotic crust over the nasal bridge and palate. 𝐂𝐻 demonstrates broad ribbon-like acetate hyphae. And what is the most likely etiological agent? Jaldi, just answer me in the chat box ki what could be the possible answer here. There is a diabetic patient and who is having an uncontrolled diabetes, but now he is having fever along with some black necrotic crusting. पहले हमने बताया था कि yellow crusting was an impetigo. अभी the question says that it's a black necrotic crust, so and that too over the nasal bridge and the palate. Now we are going towards a fungus because when we see that the 𝐂𝐻 is done, the 𝐂𝐻 is showing a acetate hyphae. Options are Aspergillus, Rhizopus, Candida, Cryptococcus neoformans. Excellent. So I'm getting both the answers here. Yeah, some of you are getting it right. So the correct answer here should be Rhizopus aureus. Now here, what is the diagnosis? If you know this is the organism that is going to cause this kind of a symptom, then what is the diagnosis here? Here the diagnosis should be, I got the diagnosis here in the chat box. Excellent. Synergetic was answering it. So here the correct diagnosis would be rhino orbital mucormycosis. So when I say mucormycosis, it will be much more clear, right? So mucormycosis is going to be the diagnosis because this can be usually seen in diabetic patients or it can be seen in immunocompromised patient. And when you do a KOH test, you can see a acetate hyphae with a right angle blanching, right? So that is how you will be able to identify and diagnose all these things. Clear? So this is a typical presentation of mucormycosis. Now going to the next question. So the next question says a 25-year-old woman has a recurrent painful grouped vesicles on an erythematous base in the lip region. Zank smear reveals multinucleated giant cells. What is the probable diagnosis? I started getting the answers. Dr. Moin says B. Fine. How many of you? Okay, someone says A. Any more answers? Hmm? So let's again see what is happening in this question. In this question, there is a patient who is having recurrent painful vesicles over the lips. Matlab, this symptoms is recurrent. The patient may be getting this symptoms recurrently, and these are painful vesicles over the lips region. You can see that there is a group of vesicles here over the lip region, and this is going to be a recurrent infection as well. So where do you find these kind of things, especially when you have one more clue which says that Zank smear shows multinucleated giant cells? Yes. So here the right answer is going to be HSV1 infection. Now you can see multiple options here. And remember, when it comes to HSV1 and HSV2, remember it this way, that over the waistline. Okay. So infections above the waistline is usually caused by HSV1, and infections below the waistline is caused by HSV2. That is something which you can remember, but this is not always true. This is true in 90% of the cases. Okay, in 90% of the cases, this is the actual scenario. Above the waistline, HSV1, below the waistline, HSV2. So here, since it is a lip infection, so what do you call for herpes simplex virus infection of the lips? Is there a specific name? क्या हम बस HSV infection of the lips बोलते हैं या फिर there is a peculiar name for this? Anyone? So there should be a peculiar name for this. यहाँ पे diagnosis should be, anyone in the chat box? I'm just giving you 5 more seconds. Excellent. Dr. Ghazali is answering it. This is called as herpes labialis. This is called as herpes labialis. Yeah, I'm getting more answers in the chat box. Excellent. So that is going to be herpes labialis. And the remaining options यहाँ पे जो दिया हुआ है, that is varicella zoster. So that is going to be seen with herpes zoster or chickenpox, right? And any infection or any disease that comes to your mind when you see Coxsackie virus in the option. The option D is Coxsackie virus. Any infection which is caused by Coxsackie virus. Anyone? So Coxsackie virus, one of the infection, yes, excellent. This is going to be HFMD. So what is HFMD? Hand, foot, mouth disease, right? So hand, foot, mouth disease can be caused by Coxsackie virus. Very good. Super. So that is about herpes labialis. So now let's see the next question. The next question is a 30-year-old man presents with a single painless indurated ulcer on the glans penis and a firm non-tender inguinal lymphadenopathy. What is the most likely diagnosis? So whenever you are going to deal with a question that is going to be on genital ulcer disease, we always try to reach out a diagnosis based on the painful and painless genital ulcers. So let's see, here we have this patient who is having a painless ulcer. It's an indurated ulcer, and the patient is having a non-tender lymphadenopathy. Non-tender matlab, again, painless. So there is a painless ulcer and a painless lymphadenopathy. So where does this combination work? Chancroid, primary syphilis, LGV, donovenosis. Yes, I'm getting the answers already. So before I go to this answer, please remember the painless genital ulcers, painless genital ulcers. Please remember it as a mnemonic that is going to be LSD. So just imagine ki LSD is a drug, and when you take a drug, you may not get to know the pain. Correct. So what is LSD in the cases of painless genital ulcer? L stands for LGV. Okay, S stands for syphilis, and D stands for donovenosis, and D stands for donovenosis. So please remember these three. Okay, painless genital ulcer can be seen in LSD, and LSD stands for LGV, syphilis, donovenosis. Now coming back to the question, now here यहाँ पे painless genital ulcer है. So what is one option that we can rule out? We can rule out chancroid, because chancroid will have a painful ulcer. Will have a painful ulcer. Now coming to the other options, syphilis, LGV, donovenosis. So how do we differentiate this? Syphilis is a silent disease. मतलब यहाँ पे genital ulcer is also painless, and the inguinal lymphadenopathy is also painless. So now you know what is the right answer here. This should be primary syphilis. Now let's see why LGV is not the right answer. So in the cases of LGV, LSD, right? So यहाँ पे ulcer is anyways painless, but lymphadenopathy is going to be painful lymphadenopathy. It should be a painful lymphadenopathy in the cases of LGV. And what happens in donovenosis? Because donovenosis also has a painless genital ulcer. Now the difference comes in whether it is having a painless or a painless inguinal lymphadenopathy or not. So donovenosis, remember donovenosis. ये no क्या है? This no means there is no lymphadenopathy in donovenosis. Okay, so that is how you can remember. In donovenosis, there is no lymphadenopathy. That is why we have this donovenosis, and here also no lymphadenopathy. That is all about this question. Genital ulcer disease, very, very important topic for your exams. Okay, it's a very repeatedly asked topic. So moving to the next one, a 28-year-old female has multiple soft pedunculated cauliflower-like growths in the vulva. What is the most probable diagnosis? तो यहाँ पे कोई images नहीं है. So it is just describing the image that a patient who is a female, she is having some cauliflower-like growths over the vulva. So what is it more likely to be? Condyloma lata, Condyloma acuminata, Molluscum contagiosum, Verruca vulgaris. So waiting for your answers. I'm getting the answers one by one. Yeah, just giving a few seconds for you to let me know the answers first, and then we'll discuss. Yes. So what happens here is, in which condition do you see Condyloma lata? Remember, Condyloma lata is seen in secondary syphilis. Condyloma lata is seen in secondary syphilis, whereas Condyloma acuminata is seen in human papilloma virus infection, that is genital warts. That is genital warts. Now, where do you find this molluscum contagiosum? Molluscum contagiosum is usually seen in either children, which is more common. It can also be seen in adults because it is a viral infection. Now, in molluscum contagiosum, how does the patient present to you? The patient usually presents to you with umbilicated papules. Okay, whenever you see a central umbilication, that is how you can see that this is a patient who is having a molluscum contagiosum. And the last one is verruca vulgaris, which means the most common. So this is the most common type of HPV warts, okay, human papilloma virus warts. Now here, what should be the right answer? I have explained you what are all these four cases. What do you think is the most likely based on the description that is given in the MCQ? Based on the description that is given in the MCQ, what is the most likely answer? Lata, acuminata, molluscum, verruca vulgaris. Yes. So this should be seen in syphilis. What is it? Syphilis? No. So yeah, here this is going to be condyloma acuminata. So it should be condyloma acuminata. Kyunki, if it was lata, we'll never say that there is a cauliflower-like growths. In lata, you will get a flat topped lesions. It's a very contagious or a very infectious lesion that you can see in the genitalia in secondary syphilis, but they would be a flat top lesion. Flat top lesions can never look like a cauliflower like lesions. So यहाँ पे the correct answer should be condyloma acuminata, which is going to be genital warts, which is going to be genital warts. Thank you all for answering. Yeah, most of you are answering it as option B, which is going to be the right answer here. So now let's go to the next question. A 32-year-old man has well-defined erythematous plaques with silvery scaling over the extensor surfaces. Gentle removal of the scale results in pinpointed bleeding. Which sign is demonstrated here? So this patient is having a red color plaque, okay, erythematous plaque, or scaling is described as silvery scaling, and the area is extensor surface, just say extensor surface like this. You will have to imagine that a patient is having a red colored plaque lesion, and above the plaque lesion there is a white, silvery white scaling and is seen over extensor surfaces. पहले ये बताओ कि यहाँ पे diagnosis क्या है, because the first sentence is very clear cut of a very important disease in dermatology. So what is the diagnosis here? Yes, the diagnosis here is going to be psoriasis, isn't it? The diagnosis here is going to be psoriasis. So in psoriasis, what is the sign that is being demonstrated here? जैसे gentle removal of the scales results in a pinpointed bleeding. Is it Koebner? Is it Auspit sign, candle grease sign, या फिर Nikolsky sign? Yes, in the chat box, all of you are answering it as Auspit sign. So that is a clear-cut description of an Auspit sign. If you take a glass slide, if you are going to scrape over the lesions of psoriasis, you finally would be able to see a pinpointed bleeding spot. This is called as Auspit sign. Now, what is the meaning of this one, which is called as a Koebner phenomenon? So what happens in a Koebner phenomenon? Koebner phenomenon can also be seen in psoriasis. Now, what happens in the Koebner phenomenon is that new lesions appear at the site of trauma. New lesions would appear at the site of trauma. That is called as a Koebner phenomenon. Candle grease sign is also seen in psoriasis. Okay, this can also be seen in psoriasis because when you start scraping the lesion, once the scales are getting removed, you can see a very shiny thing. That is also called as a candle grease sign. Okay, done. And the last one is Nikolsky. This Nikolsky is not seen in psoriasis. This is not seen in psoriasis. Now, who can tell me in the chat box that in which diseases can you see a Nikolsky sign? अगर आपको हिंट चाहिए कि what is a Nikolsky sign, if I apply a tangential pressure over the skin, okay, when I apply a tangential pressure, if the bulla would peel off, that is called as a Nikolsky sign. Okay? If the bulla would peel off, we are very good, Dr. Ghazali. She says that this can be seen in pemphigus. That is excellent. That is a correct answer. Pemphigus vulgaris, pemphigus foliaceus, matlab pemphigus group of diseases mein we can see uh, a Nikolsky sign. Other than pemphigus, we can also see this in a disease called as 4S. What is 4S? Staphylococcal calded skin syndrome. It can also be seen in staphylococcal calded skin syndrome. So that's about this MCQ. So now moving to the next one. A patient with chronic plaque psoriasis develops diffuse erythema and scaling and fever after abrupt systemic steroid withdrawal. What is the most likely diagnosis? Guttate psoriasis, erythrodermic psoriasis, pustular psoriasis, seborrheic dermatitis. This may be a little tricky. I would like to know how many of you have got this thing right, because this is one question which I feel that many of you may go wrong. Yes, just as expected. Now let's see here. I appreciate your thought process. All of you are thinking it in the right way. Kyunki psoriasis, this is the question itself says that the patient is having a plaque psoriasis, and we all know that systemic steroids are contraindicated in psoriasis. Systemic steroids are contraindicated in psoriasis. But here, what happens is that um, there can be two ways of taking the right answer in this question. It may be one of the controversial questions that we have for today. Let's see how it goes. Okay, we know that prednisolone jesa tablets are contraindicated in psoriasis. If you give prednisolone like tablets for a patient who's having psoriasis, what is the possibility? The possibility is that the patient may develop multiple pustules over the trunk. Fever भी हो सकता है. So fever, multiple pustules over the trunk, and this can be called as generalized pustular psoriasis. But my problem here is that in this question, there is no mention about pustules in the body. सिर्फ इतना ही बताया था कि diffuse erythema है. There is a lot of scaling as well and fever. But diffuse erythema, scaling and fever after steroid withdrawal, this can also be seen in psoriatic erythroderma. Can also be seen in psoriatic erythroderma. That is why more likely, based on this question, I would say that erythrodermic psoriasis is more appropriate answer here than a pustular psoriasis. But in case anywhere in the MCQ, if the question says that the patient is having sterile pustules, then the correct answer can definitely be von Zombush reaction or generalized pustular psoriasis or generalized pustular psoriasis. So no need to worry. Okay, just be a bit cautious when you see these kind of MCQs, because some keywords, if it is missing in the question, then the entire answer itself can be different. Okay. Now moving to the next one. A middle-aged woman presents with flaccid bulla over the trunk and painful oral erosions. Nikolsky sign is positive. Biopsy shows suprabasal acantholysis with a row of tombstone appearance. What is the most likely diagnosis? यहाँ पे आपको बहुत सारे options दिए हुए हैं. Okay, so many hints that can lead you to the right answer. Because for me, the hint is it's a middle-aged patient. And patient is not having a tense bulla. Instead, the patient is having a flaccid bulla, which means which can break very easily. And most important point for me here in this question is there are oral mucosal erosions. Okay, painful erosions भी है. Nikolsky sign भी positive है. And when you do a biopsy, you can see a suprabasal acantholysis. Suprabasal matlab above the stratum basal. Acantholysis means the keratinocytes are getting separated from each other with a row of tombstone appearance like the graveyard. So what is the answer? Too many options and too many clues for you. Yes, this is all consistent with pemphigus vulgaris. So please remember, for your exam, whenever you see any MCQ on vesiculobullous diseases, what you need to remember is in pemphigus foliaceus, you get a flaccid bulla and no oral mucosal involvement. No oral mucosal involvement. That is the most important thing. Flaccid bulla hoga, but oral mucosa is always spared in pemphigus foliaceus. Pemphigus vulgaris, a oral mucosal involvement is the first symptom, after which the patient will also develop a flaccid bulla. So no oral mucosal involvement, please go for pemphigus foliaceus. And if there is an oral mucosal involvement along with the flaccid bulla, please go for pemphigus vulgaris. तो यहाँ पे bullous pemphigoid क्यों नहीं है? Why is it not going to be bullous pemphigoid in this question? क्योंकि bullous pemphigoid में you have a bulla which arises from very deep. इसीलिए we would be able to see a tense bulla, not a flaccid bulla. And dermatitis herpetiformis, this is a disease where there is no bulla at all. You cannot see any bulla in the trunk. Instead, you can only see papulovesicles. You can only see papulovesicles. Now you understand that in the entire MCQ, everything becomes a key point. If there is a mention of bulla, you can easily rule out dermatitis herpetiformis. If there is a mention of flaccid bulla, you can even rule out bullous pemphigoid. Now, flaccid bulla can be seen in anything like pemphigus foliaceus, pemphigus vulgaris. But please remember, oral mucosal erosion means pemphigus vulgaris. So that's the takeaway message from this MCQ. I hope it is clear. Chalo. So let's go to the next question now. A 70-year-old male presents with a large tense bulla. Now again, same topic. So the moment I see this is a key word for me in the MCQ. Tense bulla on a erythematous skin over the trunk and limbs. Oral mucosa is paired. DIF shows linear deposition of IgG and C3 along the basement membrane. What is the most probable diagnosis? Can anybody answer? Just give me answers in the chat box. So what do you think is the right answer here? क्योंकि patient को tense bulla है. So if it is a tense bulla, based on what we discussed some time ago, I can rule out at least one option here, which is pemphigus vulgaris. क्योंकि vulgaris में we should be expecting a flaccid bulla. Correct? Now, next one. Yes, so I'm getting the right answer here. Everyone says that it is going to be bullous pemphigoid. Reason? क्योंकि bullous pemphigoid is usually seen in elderly patients. So यहाँ पे the patient's age is 70 years old and the patient is having a tense bulla. Oral mucosal involvement हो भी सकता है क्योंकि around 30% of the patients will have a oral mucosal involvement in bullous pemphigoid, and the etiology lies in the basement membrane zone. इसीलिए when you do a DIF, you can see that there is a linear fluorescence over the basement membrane zone or dermoepidermal junction. So the right answer here should be a bullous pemphigoid. Linear IgA disease भी हो सकता है, but linear IgA disease, even though it can be seen in elderly patients, it is more likely to be seen in children. It's the most common vesiculobullous disease in children as well. But why not linear IgA disease? Because if you see the DIF में what is deposited in this MCQ? IgG and C3. But in linear IgA disease, what is deposited in the DIF? It is going to be IgA. That is going to be deposited. IgA, which is going to be deposited linearly over the basement membrane zone. इसीलिए linear IgA disease भी नहीं हो सकता. And the last one is epidermolysis bullosa acquisita, which is usually a mechanobullous disease. Matlab, wherever there is a trauma, let's imagine that there is a child who is like hitting the hands while crying. And then once you develop this kind of a bullous lesion, whenever there is a trauma, that is a typical presentation in a epidermolysis bullosa. Correct? So here the right answer should be bullous pemphigoid. Now let's move to the next question. A 25-year-old man presents with severe pruritus, grouped vesicles over the elbow and knees. DIF from the perilesional skin shows granular IgA deposition in the dermal papilla. What's the correct diagnosis? Bullous pemphigoid, dermatitis herpetiformis, linear IgA disease, pemphigus foliaceus. Hi Javed. Okay. So yes, Ghazali says option B. How many of you agree with Ghazali? Yeah, Dr. Moin also says option B. Okay, I also completely agree with you. क्योंकि यहाँ पे क्या है ना, they have not mentioned कि there is a flaccid bulla या tense bulla. Instead, if you see this MCQ very clearly, it is mentioned vesicles are there over the elbows and knees. Now, when you see all the options, bullous pemphigoid, linear IgA disease, pemphigus foliaceus, all these are vesiculobullous diseases. पर बुल्ला मेंशन ही नहीं है एमसीक्यू में. So that is one way how you can think that it can be dermatitis herpetiformis, but you can confirm it is dermatitis herpetiformis because in dermatitis herpetiformis the DIF will show there is a granular IgA deposition around the dermal papilla, around the dermal papilla. Now, this is a very quick question regarding dermatitis herpetiformis. Is there any disease that is very closely associated with dermatitis herpetiformis? Patient can come to you with skin lesion, but is there any other disease which is associated with this condition? In the chat box, please. What is the most common association of dermatitis herpetiformis? Very good. I already have the answer in the chat box. This is going to be celiac sprue or gluten sensitive enteropathy. That is the reason why we will have to avoid like barley, rye, oats and wheat should be avoided, because every time the patient consumes, let's say chapatis, the patient will develop these vesicular lesions, papules and vesicles over extensor surfaces. That is a typical presentation of dermatitis herpetiformis. Excellent. So whoever is answering it right, amazing, very good. So now let's see the next question. A 40-year-old woman has violaceous, polygonal, flat-topped papules on the flexure of the wrist with fine white reticulate lines on the surface. What's the diagnosis? Psoriasis, lichen planus, pityriasis rosea, discoid lupus erythematosus. Okay, I'm getting a lot of answer as B. Pretty direct question, क्योंकि whenever you see this violaceous color, violaceous मतलब whenever you see this purple colored lesions in the skin, which is polygonal, flat topped, it can be pruritic, which means itchy. All those things is going to be a typical presentation of this condition, which is called as lichen planus. So it is more or less an image spotter, and along with the image spotter, it is also very clearly mentioned this is going to be purple colored, so it should be lichen planus itself. It's a very easy question. I guess all of you have got this one right. So now let's see the next question. A 28-year-old woman has limited facial vitiligo, matlab less than 5% of body surface area is involved, with perioral patches and some leukotrichia. What is the most appropriate first line therapy? तो यहाँ पे it is very clear कि diagnosis is facial vitiligo. So whatever you can see in the face, you can see that there is a vitiligo in the face. Around the oral cavity, there is some patches, some leukotrichia. Leukotrichia as in whitish discoloration of the hair. It can be some whitish discoloration over the mustache, isn't it? Over the beard hair or something. So here, what should be the first line therapy? A potent topical corticosteroid daily for 3 months, tacrolimus 0.1 percentage ointment twice daily, narrow band UVB, or a PUVA therapy? What are the answers that you are saying? Yes. So यहाँ पे the answer should be tacrolimus or pimicrolimus. So anything can be given because what is tacrolimus? It is a calcineurin inhibitor. So this is a topical drug of choice. So whenever you find that a patient is having less than 10% of body surface area, we always think of giving some creams, topical agents. So in the cases of vitiligo, which is an autoimmune disease, we can definitely go for tacrolimus or pimicrolimus. Why we should not go for a potent topical corticosteroid? ये जो potent topical steroids हैं, they are very strong, and this when it is applied to the face, it can lead to atrophy, isn't it? Facial atrophy, unnecessary hair growth, even acne, rosacea, all those things are possible when you apply it over the face. So that is definitely not a good choice. And phototherapy, which is given here in option C and D, it is usually an adjuvant therapy. ये जो topicals के साथ you can do that as well, isn't it? A is preferred is if the frequency is less. नहीं, potent topical steroids are best avoided. Okay, अगर ये mild corticosteroid है, जैसे hydrocortisone, desonide, those can be still applied to the face. Even mometasone can still be applied. But see the duration. Who will apply steroids for 3 months over the skin as over the face? That itself can lead to a lot of side effects. That is why the first option is not at all appropriate here. It's always for the face, go for tacrolimus calcineurin inhibitors, which does not have the side effects like a steroid cream. Okay, Javed. Fine. So now let's go to the next one. A 35-year-old woman has irregular symmetrical hyperpigmented macules over malar region that darken with sunlight. Which topical agent is a part of standard triple combination regimen for melasma? अभी इसमें क्या हो रहा है कि initially the examiner did not tell you what is the diagnosis, but by the time we reached towards the end of the question, the diagnosis is very clear. It is melasma. So what is the topical agent which is a part of triple combination regimen? So triple combination regimen, if you know, this is called as the Kligman formula. So Kligman formula is having three drugs. So what are those? Options are hydroquinone, isotretinoin, clindamycin, tacrolimus. Any answers in the chat box? 5 seconds for you to answer. Okay, I'm getting a lot of answer. That is A. Excellent. So hydroquinone definitely is a drug of choice in melasma, and hydroquinone is also a part of the Kligman formula, because in Kligman formula what we use is we use hydroquinone. That is one. The second one is tretinoin. Tretinoin. Abhi option dekho. This in the option it is isotretinoin. It is not isotretinoin. That should be tretinoin क्योंकि वो topical agent है. Isotretinoin is a tablet. Q synergetic. Okay, and then what is the third one in the Kligman formula? This can be a mild steroid. Mild steroid का example मैंने अभी अभी दिया था, like mometasone, isn't it? Hydrocortisone. All those are mild steroid. क्योंकि अभी फिर से हम face में apply करने वाला है because it's a melasma case. So that is about Kligman formula. So now when you see the options, the only one drug which is a part of a Kligman formula or the triple regimen is going to be hydroquinone. Yes, this is a treatment. So it's a treatment. We can get there are some brands like Melacare and all which is available. So what are the components of these creams is these three drugs together: hydroquinone, tretinoin, and a mild steroid. And a mild steroid. So that's about this question. So now let's slowly move to the next one. A young woman has unilateral blue-gray pigmentation involving the sclera and the malar region since childhood. What is the diagnosis? अभी आपको imagine करना पड़ेगा कि there is a patient who is having a bluish gray pigmentation which is only in one side of the face, and it is involving the eyes as well as the face, malar region of the face. Okay, someone says ota. So is it ota ya ito? Because these are the two words which can confuse you. Is it ota ya ito? Yeah, excellent. So this is going to be the nevus of ota, because this is an example of ceruloderma. Ceruloderma. So ceruloderma means there is a bluish discoloration over the skin. And two examples of ceruloderma can be nevus of ota and ito. Even Mongolian spot is also an example for ceruloderma. Now, where do you find nevus of ito? Ota, just like what you can see in this MCQ, ota can be seen in the face and along sometimes in the eyes as well. Not always, but sometimes in the eyes. Let's say 30% of the patients may have a scleral involvement. Now, where do you find nevus of ito? Yeah, ito back matlab, it is usually seen over the shoulder area. It is usually seen over the shoulder area. That is going to be nevus of ito. As a, you can remember like this O for ota, okay, the eye involvement, because ota and ito, the names are very close. It can confuse, and each mark or each correct answer is very important for your exam, right? Now let's see the next question. A 10-year-old boy presents with a asymptomatic, ill-defined hypopigmented macules with mild scaling on the cheeks. What is the most likely diagnosis? So here it is a child, क्योंकि just 10 years old, कोई symptoms नहीं है, it's an asymptomatic lesion, but hypopigmented macules है, hypopigmented macules with scaling. So whenever you see a child who is having hypopigmented macules, there is only two differential diagnoses. What are the two differential diagnoses? It can be either a pityriasis alba or it can be leprosy. So these are the two differential diagnosis, not vitiligo, not tinea versicolor. Clear? Now, how can I say whether it is alba or leprosy? Not A, then C. Okay, not A, then C. Logically, good thinking. But ये भी बोलना पड़ेगा कि A है या C. Yeah, C is the right answer, says. No. Now remember, in pityriasis alba, since it is considered to be a kind of a atopic or a dermatitis, here what you can find is scaling. Whereas leprosy, as you know, any patient who is having leprosy, there is no scaling. Instead, there would be a sensory deficit. Sensory deficit, like the child may not know if you are touching the skin. So touch sensation compromise हो सकता है, या फिर temperature sensation compromise हो सकता है, but nothing like that is given in the MCQ. In the MCQ, what is mentioned? Scaling. Scaling matlab the answer should be pityriasis alba. Scaling means the answer should be pityriasis alba. Okay, that is about this question. So now going to the next one. A 30-year-old female has gradual diffuse thinning of the scalp over the crown for 2 years with the preservation of the frontal hairline. Trichoscopy shows more than 20% variation in the hair shaft diameter. What is the likely diagnosis? Anyone? I'd love to hear what is the answer. Excellent. So most of you who are answering it in the chat box and the comment box, it's all correct, because all the answers I can see is a female pattern hair loss. Now, what makes you say that this is a female pattern hair loss? Because female pattern hair loss means this is androgenic alopecia, isn't it? So androgenic alopecia means it can be seen in males or it can be seen in females. One of the most important thing in androgenic alopecia is there is a thinning of the hair. वो तो हो गया, ये mentioned है, thinning of the hair is mentioned. Second thing is in females, what happens? The anterior hairline is always fixed. That is why there is a preservation of the frontal hairline is also mentioned. And in trichoscopy, the hallmark feature of androgenic alopecia is hair shaft diameter variability. Okay. तो यहाँ पे more than 20% variation आ रहा है, तो this should be a case of androgenic alopecia. Excellent. Super. So happy to get this answer right. So now let's see the next question. A 20-year-old man presents with a single smooth patch of complete hair loss on the scalp. Short, tapering, exclamation mark hairs are present at the periphery. Most appropriate initial treatment. अभी इस पेशेंट को जनरलाइज्ड या फिर डिफ्यूज एलोपेशिया नहीं है, इंस्टेड यहाँ पे ना पैची एलोपेशिया बताया था, isn't it? Patchy alopecia. So in patchy alopecia, you can see that there is an exclamation mark hair. So what is this exclamation mark hair? So we all know that an exclamation mark looks like this. So when you look in a trichoscopy, if the hair over the part nearby the scalp is very thin and away from the scalp is going to be broad, this is called as exclamation mark hair. Now where do you find exclamation mark hair? Yeah, synergetic is already answering. यहाँ पे diagnosis होना चाहिए alopecia areata. So alopecia areata में what should be the initial treatment? Intralesional corticosteroids, oral methotrexate, minoxidil lotion, systemic corticosteroid. What is the answer? Javed says A. How many of you would like to go with Javed? That the correct answer is A. Dr. Moin also confirms it should be A. Excellent. So please remember, whenever you see a single smooth patch, okay, along with exclamatory mark here, diagnosis is alopecia areata. If it is a smooth single patch, then what you can do is a localized treatment. Localized treatment as in you can give an injection of a corticosteroid at the site. So can you tell me any example of a intralesional steroid? What is an intralesional steroid? Any example of an intralesional steroid? I can give a clue. It starts with the letter T. It should be triamcinolone. You must have learned about triamcinolone. It is used in keloids as well, isn't it? So triamcinolone, yes, Javed, very good. Synergetic is also answering. Dr. Ghazali is also answering. So triamcinolone can be used as an intralesional steroid for the management of alopecia areata. Now see this question. Next one. A 19-year-old male with severe nodulocystic acne on isotretinoin has triglyceride 450 mg per dl at 6 weeks. What is the next step? Now, this is a question about acne vulgaris. So the patient is having nodulocystic acne. So that is the most severe type of acne. So what is the drug of choice in nodulocystic acne? हो गया systemic retinoids. The example is isotretinoin, right? So if you give a patient isotretinoin, one of the side effect is dyslipidemia. One of the side effect is going to be dyslipidemia. We know that there are many other side effects. जैसे teratogenic drug है, so there is a 1 month of teratogenicity. Dry skin हो सकता है, night blindness हो सकता है, depression हो सकता है. All these are the side effects of a isotretinoin. But here the question is testing you about dyslipidemia. If the patient comes back to you for a follow-up and you see that the triglyceride is 450, what will you do? Stop isotretinoin permanently, add a fibrate and continue isotretinoin, add a statin and continue isotretinoin, or switch to oral antibiotics. What will be the answer? Just waiting for your answer in the chat box. Anyone? Two more seconds. What is the answer? So remember that since dyslipidemia is a side effect of isotretinoin, what you can do is, okay, doubtfully you are asking you if it is B. चलो देखते हैं. The idea here is isotretinoin, it can raise TG levels, okay? But if the triglyceride is less than 500 mg per dl, okay, if it is less than 500, then what you can do is you can give some tablets which can reduce the triglyceride. So which tablets can reduce triglyceride? Is it atorvastatin or rosuvastatin, or is it something else? Triglycerides can be reduced with the phenofibrates, right? So we can start with fibrates. Whereas if the range of a triglyceride will go very, very high, like it can be more than 500, but theoretically, if it goes more than 800 mg per dl, then what you have to do is you have to stop isotretinoin. You cannot go continue with isotretinoin if it goes beyond 800 mg per dl, because what will happen is if TG goes very high, there is a chance of pancreatitis. There is a chance of pancreatitis. So that is why, since there is a risk of pancreatitis, hence we will definitely stop if it is goes beyond 800. पर यहाँ पे question में क्या बताया? 450 mg per dl. 450 is definitely high. So since it is high, what do we start? We start on a fibrate. Why are we not starting on a statin? Because statins can only reduce the cholesterol, not triglyceride. Yeah, very good. So yeah, all the answers I would agree. So that is the answer for this MCQ. Now moving to the next one. A 42-year-old woman has a persistent central facial redness with flushing, papules, telangiectasia, and comedones are absent. What is the likely diagnosis? Now here, it is a female patient. Comedones are absent is what strikes me in this MCQ. So where do you find comedones? Comedones are seen very typically in acne, isn't it? अगर comedones are absent, I'm definitely ruling out the first option. ये acne vulgaris तो नहीं हो सकता. So here the patient is having a red colored facial redness in the face with flushing as a symptom and telangiectasia. अभी options देखो. Rosacea, seborrheic dermatitis, lupus erythematosus. Answer. So here all these can be presenting like this, but the most appropriate answer here should be rosacea, क्योंकि this symptom that you can see flushing, that is flushing is very, very typical for rosacea. And in lupus erythematosus, there is not going to be flushing, even though the patient can present to you with red color rash, which is called as a malar rash. It can be a malar rash as well. So moving to the next one, a 25-year-old man develops fever, mucosal erosions, widespread skin peeling 1 week after sulfonamides. Nikolsky sign is positive, most probable diagnosis. So यहाँ पे it's very clearly said that after taking sulfonamides, the patient is developing fever, mucosal erosion, and widespread skin peeling. So see the options now. Erythema multiforme major, Stevens-Johnson or toxic epidermal necrolysis overlap, fixed drug eruption, acute urticaria. Yes, I guess it's an easy question because this should be SJS or TEN overlap, right? Why? Because mucosal erosions is there, drug history is given, and there is a massive peeling of the skin. All these things. Whereas erythema multiforme, it can also be caused by drugs, which I agree. Mucosal erosions भी हो सकता है, but not skin lesions, right? Skin में क्या देख सकते हैं in erythema multiforme? In erythema multiforme, you can see target lesions, isn't it? Bullseye lesions and all can be seen, but there is no peeling of the skin, isn't it? So this is a condition which can be caused by drugs or infections. Whereas fixed drug eruption will be having a lesion at a fixed site, not massive peeling of the skin. And urticaria, it definitely does not fit. That is why here the right answer should be Stevens-Johnson syndrome or toxic epidermal necrolysis. Next question says 3 weeks after starting allopurinol, can be a drug which is used for gout and all, isn't it? A patient develops fever, facial edema, generalized rash, eosinophilia, and transaminitis. What is it? What reaction is this? Any answer in the chat box? Option B. Yes, very good. This is called as Druss syndrome, isn't it? So what is Druss? It means there is a drug reaction, isn't it? With eosinophilia and systemic symptom. So this is called as a drug reaction with eosinophilia and systemic symptom. Typically, क्या होता है? The patient will be having fever. There may be a periorbital edema or a facial edema. Along with that, most importantly, there will be a raised eosinophil. So eosinophilia can also be seen. So all these things are seen in Druss syndrome. It is seen in Druss syndrome. That is another MCQ on drug reactions. I guess we have one more question on the drug reactions today. Let's see what is this question. A patient presented with treated with doxycycline develops painful erythema and burning on sun exposed face after an outdoor activity. So let's imagine that the patient was given doxycycline, they say for some disease like acne vulgaris. So you're giving doxycycline for several weeks or months together. The patient goes to the sun and then he comes back with some reaction with a painful erythema and burning. Is it a photoallergic reaction, phototoxic reaction, fixed drug eruption or photoonycholysis? Onycholysis तो बिल्कुल नहीं है क्योंकि onycholysis means nails, right? So not that. So fixed drug eruption, it should be in a fixed site. That is also less likely क्योंकि यहाँ पे बताया था कि sun exposed face is having the symptom. Now you are left with two options. Is it photoallergic or phototoxic? Any answer? So whenever there is a dose dependent non-immune, isn't it, damage within few hours, that is going to be a phototoxic reaction. It is going to be a phototoxic reaction. It can be seen with various drugs. So tetracyclines like doxycycline is one of the options. Thiazides can also show this. Even amiodarone, the antiarrhythmic drug, can also show this kind of a phototoxic reaction. Okay, this is going to be phototoxic, not photoallergic. Next question. A 28-year-old woman develops multiple transient pruritic wheals after eating seafood, and each lesion is going to resolve in 12 hours without any pigmentation. और ये image जो है very typical है. What is it? Very easy question. So what is this image? You can see that there is some edema which is present underneath the skin. This edema, it developed after taking seafood and the lesions are resolving on its own without any pigmentation. Erythema multiforme, acute urticaria, fixed drug eruption, या फिर angioedema. Yes, these are very good, Javed. So this is called as wheals, and wheals means there is some edema underneath the skin which resolves. By definition, it resolves within 24 hours, or this MCQ says within 12 hours everything has resolved. So this is a typical feature of acute urticaria. So this is going to be acute urticaria. So now let's see the next question. A 60-year-old man presents with a slowly enlarging pearly papule with rolled border and telangiectasia on the nose. So here it is a 60-year-old patient. There is a slowly enlarging papule lesion with a rolled border. Rolled border means, yeah, it may be having some border like this, isn't it? Rolled up border and telangiectasia in the center. Basal cell carcinoma, squamous cell carcinoma, keratoacanthoma, or melanoma. Very good. Moin is answering. So this, whatever is mentioned here, is a typical appearance of a basal cell carcinoma. Reason is, whenever the age of the patient is more than 55, we always keep chances of malignancy in the front. Differential diagnosis will take a shift. Second thing is face, nose, all those things are the most common site of which disease, of which carcinoma, that is the basal cell carcinoma. So typically rolled up border हो सकता है, central telangiectasia हो सकता है. This is all very typical of basal cell carcinoma. It's very typical of basal cell carcinoma. Yeah. The next question is, a 55-year-old man develops a non-healing ulcer over a burn scar which is present for 10 years. Examination shows an indurated ulcer with raised everted edges. Probable diagnosis. This is a very typical history once again. A patient is having a burn scar which is present in the skin for 10 years. So the history is very long. 10 years पहले कुछ burns हुआ था and that burn scar is over the skin for such a long period of time. After 10 years, what is happening? The patient is developing a non-healing ulcer over the burn scar. Typical clinical scenario, right? Yes, I'm getting the answers as well. Is it basal cell, squamous cell carcinoma, melanoma, or pyoderma gangrenosum? Yes. So here the right answer should be squamous cell carcinoma, and this is called as Marjolin ulcer. So squamous cell carcinoma which develops over the site of wounds or burns, this is called as Marjolin's ulcer. And why not pyoderma gangrenosum? See, in pyoderma gangrenosum also, the patient may present to you with a non-healing ulcer. Patient may present to you with a non-healing ulcer in pyoderma gangrenosum, but this usually does not happen over burn sites, isn't it? This usually happens in patients who may be having rheumatoid arthritis or hematological malignancy or irritable bowel disease. So if the MCQ had said any of these diseases, then we could have suspected about pyoderma gangrenosum, but not in this case. Next question. A 45-year-old woman has a pigmented lesion with asymmetry, irregular border, color variation, diameter more than 6 mm. All those things are going to be very, very typical of some disease that we know, because these points, asymmetry, border irregularity, color variation, diameter. Now this is A, border is B, C is color, and D is diameter. So are we talking about A, B, C, D, E algorithm? So what is this A, B, C, D, E algorithm? That is going to be very typically done for cases of melanoma. That is done for all the cases of melanoma. So yes, that is the right answer. Glad that all of you are getting it right. Next one. A HIV positive male presents with multiple violaceous nodules and plaques over both the legs. Histology shows spindle cell proliferation with slit-like vascular channels. What is the most likely diagnosis? Kaposi sarcoma, angiosarcoma, hemangioma, mycosis fungoides. Now here, patient is HIV positive. Patient is having violaceous plaques and nodules. Violaceous means purple. Now, if you have read about this topic, purple colored skin lesion in a patient of HIV, you are not thinking about lichen planus here. Instead, what are you thinking about? Yes, you are going to think about Kaposi sarcoma. And what is Kaposi sarcoma associated with? This is going to be associated with human herpes virus. Which human herpes virus? Yeah, it is going to be HHV8. So it is an HHV8 associated vascular kind of a neoplasm. So this is the most common neoplasm that is seen in HIV patients. It is called as the Kaposi's sarcoma, where the patient can present to you with violet color or violaceous papules, plaques, or even nodules. Please remember, in one of the INICET exam, you got an image of violaceous lesions within the oral mucosa. In that case also, if it is an HIV patient, please think about Kaposi sarcoma, क्योंकि ये skin में भी हो सकता है या फिर it can also be seen in the oral mucosa as well. So that is going to be the right answer here. Next one. A 35-year-old man has a painless, slowly progressive plaque lesion over the neck without systemic symptoms. Now, thoda tricky question hai. What is the next appropriate investigation? Now, what is the answer that you feel is the right one? There is a slowly progressive plaque over the neck region, but without systemic symptoms. It can be another controversial question. It depends upon what is the perspective in which the examiner takes the question, right? So, but still, let's see. KOH mount, skin biopsy, chest X-ray, or a gram staining. Most of you are going for option A, KOH. Exactly. Now here, I would not say that you're wrong here, because here what the option which I can easily rule out is skin lesion hai, so why should we go for chest X-ray on the first place, right? And then slowly progressive plaque lesion, why to go for a gram staining? So these two options I can rule out. Now, in case the question had said that the patient is having some itchy lesion, painless itchy plaque lesion extending bigger, something about scaling and all, I would be rather thinking on tinea corporis ringworm, isn't it? I would be thinking that it may be a fungal infection. But since there is no mention about itching, progressive lesion बताया है, there's no mention about scaling, all those things. For me, I feel that okay, skin biopsy would be a more appropriate answer than KOH, but KOH again cannot be wrong. Okay. Yeah, every NEET and INICET favorite. So here the most appropriate answer here should be skin biopsy. पर ऐसे वाले questions में थोड़ा logically सोचना पड़ेगा कि it can be either a fungal. What am I thinking about here? I'm thinking about a fungal infection like ringworm, like tinea, versus I'm thinking about something like lupus vulgaris. Lupus vulgaris. Why lupus vulgaris? Because only one plaque lesion is there, slowly progressive lesion, especially it is mentioned as neck region. But yes, something what is no and without any systemic symptom. So इसीलिए it can be skin biopsy. Okay. Let's go to the next question now. A 28-year-old male presents with a grouped vesicles and a superficial ulcer on the glans penis. Zank smear shows multinucleated giant cells. Drug of choice. Earlier we did a very similar thing. Grouped vesicles था, वो भी painful lesions थे, isn't it? Zank smear showed multinucleated giant cells, but उस time पे we had an image and the image was around the lips. वो herpes labialis था. अभी what is the diagnosis? यहाँ पे diagnosis होगा herpes genitalis. Herpes genitalis as in it is an HSV2 infection, right? So here, what should be the drug of choice? Benzathine, penicillin, acyclovir, azithromycin, or ceftriaxone? Yes, since it is herpes, the answer should be acyclovir. The answer should be acyclovir. Okay. Next question. A sexually active man with a purulent urethral discharge is diagnosed with gonorrhea and is resistant to penicillin, current drug of choice. So here, azithromycin, ceftriaxone, ciprofloxacin, cefixime. What is the right answer? Azithromycin. Okay. Please remember here, the diagnosis is very clear. It is going to be gonorrhea. So in the cases of gonorrhea, our drug of choice should ideally be ceftriaxone, single dose, 500 mg IM. And in case, the most appropriate should be that in case chlamydia is not ruled out, then we can add doxycycline also if chlamydia isn't ruled out. Okay, if chlamydia isn't ruled out, then doxycycline can also be added. So here the most appropriate answer should be ceftriaxone 500 mg IM, single dose. Which of the following drugs are safe and effective in the treatment of scabies? ये जो last INICET exam में आया था, right? So what is the treatment of scabies in infants? Now it is clearly asking infant. Infant means less than 1 year of age में अगर scabies है, then what is the treatment which is safe? Permethrin 5%, yes or no? Benzyl benzoate, protamidone, or ivermectin. So यहाँ पे this can be a multiple correct type of a question, because please remember that any infant like more than 2 months, infant if it is more than 2 months of age, we can definitely go for permethrin 5%, which is going to be a safer option. In more than 2 months, it is going to be a safer option. Benzyl benzoate, this is actually a skin irritant as well. So this, since it is a skin irritant, this cannot be the right answer here. Protamidone, its potency is comparatively less, but this is a safer option, but mostly it helps to alleviate the itching and all. But protamidone, yes, it can be used in the cases of scabies. And the last one is oral ivermectin. Can we give oral ivermectin? Oral tablets again in infants, bilkul nahi. But if you check about this drug ivermectin, this is going to be contraindicated. In whom it is going to be contraindicated? When you go with the body weight, if it is less than 15 kg, it is going to be contraindicated. Or let's say 5 years of age. So less than 5 years of age or less than 15 kg, ivermectin is going to be contraindicated as well. So here the right answer should be permethrin and crotamid. The next one, a patient who had a painless genital ulcer over 2 months now develops copper colored maculopapular rash involving the palms and soles. ये जो copper colored rash in the palms and soles, so typical for one disease. What is that disease? What investigation will confirm the diagnosis? Anyone in the chat box? What is the disease that we are talking about? Yeah, here genital ulcer का हिस्ट्री है और उसके बाद अभी मैक्युलोपैपुलर रैशेस भी है, तो यहाँ पे डायग्नोसिस होना चाहिए सेकेंडरी सिफिलिस. Secondary syphilis. Yeah, treponema. Very good. So in secondary syphilis, what is the investigation that you can do? Dark field microscopy, Zang smear, VDRL, gram stain. I can easily rule out Zang smear because it is done for viral diseases like HSV, varicella and all. Gram staining, it is done for bacterial infections. So यहाँ पे now we are left with dark field or VDRL. Please remember, dark field microscopy is the investigation of choice in primary syphilis. In secondary syphilis, we can definitely do a VDRL, even though it is not very specific. Isn't it? Sensitivity to hoga, but it's not a very sensitive, it's not a very specific test because it's considered to be a non-treponemal test, right? But actually FTA, ABS, all those things is going to be the more appropriate answer for diagnosing secondary syphilis. But here the best answer should be VDRL because dark field microscopy is not going to yield you a result. It is not going to yield you. Next one, which of the following is not a side effect of a prolonged topical corticosteroid use? This is also a question that was asked in the last INICET exam. So what is not a side effect of a steroid? Skin atrophy, hypertrichosis, acneiform eruption, blue pigmentation. Is the answer? Yeah, all of you are getting it right. Blue pigmentation is not associated. Skin atrophy is the most common side effect. Hypertrichosis हो सकता है. Acneiform eruption, especially once you use steroid creams in the face, it's a very common side effect as well. But blue pigmentation is not typical. It is not mentioned that it's a side effect of a steroid cream. So yes, so that is all about today's discussion. I guess we have discussed around 30-35 questions today. And thank you so much for being a very interactive crowd. Okay. And I really hope that all of your preparations are going well in good shape. And in few days time, we definitely have a workbook based session for INICET as well. And I wish you all the very best for your exams. And please feel free to contact whenever you need any assistance in dermatology. Thank you. Thank you so much.